All right, we'll go ahead and get started. Good morning, everyone. So topic for today's grand rounds, we're going to talk about turf toe, have a little discussion about the management and the outcomes for turf toe. So brief outline, kind of framework we're going to go through. We're going to talk about the background, a little bit of epidemiology, talk a little bit about the history of it, the anatomy, talk about what we're going to look for when we're working this up, how we're going to treat it, and we'll wrap up with looking at a couple of cases. These are the objectives. So we'll get started. So with the background, so turf toe, the injury itself really gained attention and really started to show itself in the 60s when athletic playing surfaces and fields started to be transitioned towards artificial turf. Artificial turf was really developed as a way to help, athletic facilities and fields maintain a cost-effective way to maintain their playing surface. With the use of artificial turf, there was no more grass really to maintain, no more soil to really keep an eye on, and just kind of really helped with the overall cost. And it was also praised that it could be suitable to help with indoor stadium use. So AstroTurf was the first big commercial variant that was introduced and was named as such as was placed in the Astrodome in Texas. Since then, there's been a lot of generations and iterations advancing on the technology of artificial turf. But the turf toe injury itself, which is a hyper-dorsiflexion injury of the first metatarsal joint, was first described in the literature in 1976 by Dr. Bowers and Martin down at the University of West Virginia. They saw that there was an increase in this specific type of injury pattern when they noticed that their football fields all began to be transitioned to an artificial surface. So what they kind of hypothesized was driving this increase in what they saw was they thought it was kind of a shoe surface interaction. So they thought that the flexible athletic shoes at the time, they weren't really using cleats, the flexible running shoes that players were using when playing on the artificial turf, which is laid over a very hard surface, like for example, concrete, didn't have the natural give, didn't have a give like natural grass would, and there was too much flexion when they were being used. So today there's been a lot of improvements in footwear and turf field itself that's really decreased the overall incidence of turf toe, but it's still pretty relevant and can be a relatively impactful injury. So looking no further, despite now that we've come a long way, it's still making front pages of ESPN. This was from a couple years ago, but as the title of the article says, turf toe is still something that is talked about a lot and definitely can be a pretty impactful injury even in the 2020s and still makes headlines. So despite all of our advancements in athletic care, turf, shoe wear, it's still a pretty relatively concerning injury when it does occur. So looking more into the epidemiology incidence of turf toe, historically, it did have a higher incidence and a pretty high impact. In a study from 1994, they found that injuries to the foot were the third leading cause of missed playing time among collegiate athletes. And turf toe was found to be a majority of those foot injuries. And going back a little bit more, a survey of 80 active NFL players in 1989 found that 45% of these reported that they had sustained a turf toe injury at some point along their career, with many of them reporting that they were sustained while playing on a artificial turf field. More recently, however, this incidence has dropped. So there was a recent study in 2014 looking specifically at NCAA football players, and the incidence was found to be 0.062 per 1,000 athlete exposures, or approximately one per a little over 16,000. Where an athlete exposure is defined as any one athlete participating in a practice or game, which there is a possibility of sustaining an injury. So while turf toe gets a lot of attention through football, it's not a football injury by itself. In 2011, there was a study from England looking at the highest level of rugby competition in England, the Premiership. They found that turf toe also comprised of 11% of all the reported foot injuries sustained over those 4 seasons. So in the end, turf toe is a pretty common injury that can be seen in all sports, but it does have a higher incidence towards contact sport played on a field or some kind of hard surface. For example, ballet dancers has also been reported to be an issue as well, given the time they spend on their forefoot and the hard surface. So looking a little bit at the anatomy, the first metatarsal joint is kind of the key to all this. The first metatarsal joint is also a very critical joint when it comes to weight bearing. When you think about it, during our gait cycle and during our athletic endeavors, a lot of the body weight has to go through the first metatarsal during our walking and running cycles. In a heel strike, heel toe walking, you're transmitting the load from the heel through the forefoot, which is going through the first metatarsal. But when we start looking at more high intensity athletic activities, for example, sprinting, your gait cycle becomes more of a forefoot strike, and you're much more loading significantly higher through that first metatarsal joint, and it becomes much more prominent due to the shorter contact time that allows you to get faster foot speeds. So they would say that sometimes through certain athletic activities, such as a sprinting to a jump, like a running jump, the first metatarsal joint can be subject to loads up to nearly 8 times your body weight. So very important joint to be very stable. The joint itself is formed by the articulation of the convex metatarsal head with a concave phalangeal base, and they kind of create this cup that gives you a large sagittal arc of motion in dorsi and plantar flexion. The complete range of motion is around 75 degrees dorsiflexion with 35 degrees plantar flexion, but the relative functional range of motion is about 80 degrees between the two, approximately 60 dorsiflexion and 20 plantar flexion. The metatarsal itself on the plantar surface has these recesses, which allow the medial and lateral or tibial and fibular sesamoids to articulate with it, and whose specific function and significance we'll dive a little bit more into later. So the inherent shape of the articulation of that first metatarsal joint, it doesn't provide a whole lot of inherent stability at the articulation. So the stability of the joint and its ability to withstand a lot of the loads we put on it is really reliant on the integrity of the soft tissue capsule. That includes the joint capsule, the collateral ligaments, as well as the flexor hallucis brevis and the sesamoid complex. The plantar plate is really the primary stabilizer during dorsiflexion, and it's a thickening of the plantar joint capsule itself that attaches to the base of the proximal phalanx, and it comes up proximally, and it begins to envelop the sesamoids and the tendons of the flexor hallucis brevis. And these all kind of come together to form one continuous unit called the capsuloligamentus complex. Further stability is given by the intersesamoid ligaments between the two sesamoid bones, and as well as phalangeosesamoid ligaments. So as mentioned, the sesamoids are contained inside of this entire complex, and these help provide stability. They also help to provide a mechanical advantage for this as a sesamoid itself to help with the mechanical pull of the flexor hallucis brevis. And they also help with absorbing the weight-bearing loads across the joint. Usually the medial sesamoid is a bit larger and plays a little bit larger role in weight bearing. So we often see this sesamoid more injured in injuries. Varus valgus stability to the joint is given by the collateral ligaments, which comprise of the metatarsal phalangeal ligaments and some contributions from the metatarsal sesamoid ligaments that are on the medial and lateral aspect of the joint. Finally, the FHL, doesn't really comprise a lot of stability, as we can see on this diagram. It's sitting at the most plantar surface outside plantar to the plantar plate itself. So while it's there, it doesn't confer a lot of functional stability to the joint itself. So looking more at the etiology and the cause of injury, the plantar plate is really the center of where the injury occurs. So the most classically described mechanism, as we see here, is an injury where an axial load is applied to a forefoot that is planted and fixed with the rest of the foot in a plantar flex position. Often they say this is what occurs when another player falls on another player in kind of this position, but it can also be seen in non-contact scenarios with cutting and pivoting. As a result, these all produce an exaggerated dorsiflexion of the first metatarsal joint that pushes the soft tissues beyond what they can withstand. This is often associated with a combined valgus force, a lot of times with the non-contact cutting injuries that can also cause stress and failure to the medial stabilizing structures that will be called the traumatic hallux valgus or traumatic bunion that we'll talk about a little bit later. So moving on to how these patients present, there's a pretty wide range in how they present in terms of both their severity and their acuity. So they can range from presenting pretty acutely right after a sporting event where the patients can actually pinpoint a specific play or incidents that caused the injury, but they can also show up in a more chronic or overuse presentation, just a lot of times complaining that they're experiencing push-off pain or push-off weakness during their gait. And if you really watch the way they walk, some of these patients, you'll find that they're begin to compensate and find ways to offload the first metatarsal joint. A lot of times you'll see them walking more in supination to have the lateral side of the foot in contact with the ground to really offload that first metatarsal joint. So when we look at the patients for their exam, we always start with the usual inspection, palpation of the joint itself. And one thing to note is that if on the exam you find that the tenderness is not really located on the plantar aspect of the foot, but is actually more proximal to the sesamoid itself, that can be important to note, as this can be indicative of more of a flexor hallucis brevis strain as opposed to a true turf toe injury, which then is a whole different injury and doesn't really quite need as aggressive as treatment or monitoring as turf toe would. Other differentials to be mindful of are sesamoiditis, which is often presented more as an overuse injury, as well as another variant called the sand toe, which is more of a hyperplantar flexion injury versus dorsiflexion, which is turf toe. So if on the exam itself, there's a specialized exam maneuver that can be used to assess the stability of the joint, and that's the vertical Lockman or the vertical drawer test. And in this diagram here, you can see that this test is performed by placing a dorsally directed force on the proximal phalanx while you're holding the metatarsal stationary, and you're trying to bring the phalanx dorsal and seeing how much motion you have. And this exam can be graded in the schematic shown below, with 0 showing no motion, and with each level increasing levels of motion until you reach an entirely dislocatable joint in the higher grades, which is 3 and 4. One thing that we're going to note about is the presentation of a chronic turf toe. So chronic turf toe presents that often are injuries that patients may have sustained earlier, but they were missed or not really treated. But this, in a way, is an entirely separate problem, which we're not really going to go into in the confines of this talk. So if turf toe goes untreated, there's a lot of progressive consequences that can develop: progressive arthritic toe or hallux rigidus. They can develop a more progressive bunion or hallux valgus. But we will talk a little bit later about a specific case where the injury causes a very more acutely progressive hallux valgus, which we'll go into in the talk discussion. One thing also to note is that in the chronic presentation, the patient may present and they may notice a specific cock-up hallux deformity or somewhat of a claw toe. So this occurs due to the instability of the metatarsal joint that causes it to extend, but the pull from the flexor hallucis longus puts the IP joint into flexion, and that's kind of what causes this appearance. But in the chronic setting, in a true chronic setting, this often is more of a reconstructive procedure as opposed to kind of a turf toe procedure, as we will talk about. So in terms of diagnostic imaging, we always start with our plain films of the foot, AP lateral. We'll always obtain weight-bearing films if the patient is able to, but that may not always be possible given some of the acuities of the injury. It's very also important to use the medial and lateral obliques to assess the sesamoids, as well as you may need contralateral films, as in up to 25% of people, it's been reported that bipartite sesamoids are present. So it's important to know whether or not you're seeing a sesamoid fracture or if it's just their anatomy and they have bipartite sesamoids. Another view that can be helpful is, of course,
just one comment there. Just one comment. Not everyone has bilateral. You have a bipartite sesamoid. Not everyone has bilateral. So that is a very good thought. A lot of people do have bilateral, but just because you see it on one side doesn't exclude that it's bipartite if it's not on the other side.
Thanks, Dr. Shaver. So you're right. So another view that can be very helpful is the forced dorsiflexion lateral view, and this can help you determine stability. So in this kind of schematic here, you see how this view is performed. So you kind of determine the distance between the distal end of the phalanx and the sesamoid, and you kind of see how much that space increases as you push the toe into the hallux into dorsiflexion. If you see increases in 3 millimeters or more, that is suggestive of a plantar plate injury. If you're able to in the office, live fluoroscopy can also be very useful, as you can kind of watch the dynamic tracking of the sesamoids with dorsiflexion. Usually you should see the sesamoids distally track with the hallux when it is brought into dorsiflexion, but if you're not seeing evidence that there's sufficient distal tracking, that is also evidence to suggest that there is a plantar plate injury. At the end, MRI is the most sensitive imaging modality for assessing these injuries, as it gives us a very good picture of a soft tissue injury, including any capsular or ligamentous disruption of the plantar plate. And it also can be used as many times, since many times this is purely a soft tissue injury, the radiographs may not be very apparent. So MRI is often used to confirm the diagnosis. Of note, I saw this kind of mentioned out there in the literature, ultrasound has been mentioned to be used as more of a point of care to be able to assess the sesamoid tracking and dynamic stability, similar to live fluoro, but the use of ultrasound, as we know, kind of operator dependent, so may not be the most useful at times. So looking at the classification system, the first true classification of turf toe was proposed in 1994 by Clarendon Ford, and then in 2002, this was modified by Anderson, which included MRI findings, which you'd see, as well as they kind of gave a framework for projected return to play guidelines. So grade 1 is characterized as more of an attenuation or a very low-grade sprain of the plantar plate that usually is managed supportively. Grade 2 is a partial tear, and grade 2 has a kind of a wide range. You can have a grade 2 that's closer to a grade 1 or one that's functionally a grade 3 with there's still some minimal amount of plantar capsule still intact, but it's not a grade 3 by definition, as it's not a complete tear. Grade 3 is a complete tear, and oftentimes with these higher grade injuries, you will see sesamoid retraction, proximally, as well as possible fractures, and these may be able to be assessed on radiographs as you may see fractures. So now we'll start looking at our treatment options. As with most things in orthopedics, we have our conservative or non-operative management and our operative options. Non-operative treatment is, for the most part, the go-to choice for grades 1 and 2 injuries. But we'll go through the literature and look more in depth about it. But in really any grade of turf toe, 1 through 3 could be managed definitively with conservative management, depending on what the situation calls for. Operative treatment is usually recommended for grade 3 injuries or specific indications such as failure conservative management, traumatic deformities, hallux valgus, loose bodies, but we'll go more in depth into all the specific indications. And usually the techniques broadly comprise of end-to-end repair of the plantar plate when able, or suture anchor repair with advancement. So now we'll kind of go into our non-operative management, and we'll look at these by grade. So starting off with grade 1, this is our most mildest form of injury. The plantar complex is intact. The joint is going to be stable. So really the treatment is just supportive care and getting the patient or the athlete kind of through the painful phase and back onto the field. Usually they can be weight bearing as tolerated. They could use a boot if it makes them more comfortable, but usually not necessary. And treatment to help them get back to play is really symptomatic based. There can be taping, orthotics. Usually this orthotic, the more an extension, or it can be made of carbon fiber or a turf toe plate. It could also be used of steel, I saw. This can be placed into their cleats or shoes to really help prevent further dorsiflexion and help them with pain. In terms of returning to play, the patients are free to return to play as quick as they're able to. So really it's as symptoms dictate. So moving on to grade 2. In grade 2, there is some form of a partial tear to the complex. And depending on how severe that may be, the patients may not be able to weight bear fully due to the pain, as well as there could be a further risk of injury of complete tearing if they were to push it further. So conservative treatment for these is usually implemented first, and it's ranges from protective weight bearing in a cam boot, or they may be totally immobilized in this toe spica immobilization for a period of time, usually 1 to 3 weeks. Afterwards, recovery is a very slow advancement, which progresses from range of motion and then progresses towards low impact activities such as walking. And then after that, they progress to jogging and running. And usually the clearance protocol to get them back into their sport is when the patient is able to run at their normal clip and pace pretty comfortably without any significant pain. After that, high impact activities will allow it to be instated. So with grade 2 injuries, as these seem to be one of the more common forms, there's a lot of question into whether or not injections can help. Corticosteroids is usually avoided as the treatments can mask the symptoms, which could be a good thing, but we know that the corticosteroid injections can hinder the healing of the capsule ligamentous tissue itself, so these are really not recommended. There has been some interest in whether or not biologics or PRP has a role in the treatment. So looking at this, there is some studies out there, well, more specifically, one study out there that looks specifically at the use of biologics for turf toe itself. So as with many studies involving the biologics, they're really limited to case series of a couple of patients and they're relatively on the lower level of evidence side. The science behind it is that the amount of growth factors and cytokines you can concentrate in these injections can help with the healing effect, and more importantly, they have an anti-inflammatory property that can help with the swelling and the pain. So in this kind of case series study in 2016, they presented a case series of 2 athletes who sustained grade 2 turf toe injuries and that were injected with biologics, and both had good outcomes. Both were D1 collegiate running backs. They both had grade 2 injuries as diagnosed under fluoroscopic examination, but didn't show any gross joint subluxation or instability. The first athlete reported that they had pain while getting out of a stance and then began to have limited ability to push off. So this patient underwent a period of the usual RICE therapy, rest, ice elevation, taping, but was still symptomatic. And as a result, he had an injection of autologous conditioned plasma, which is similar to PRP and Toradol, 2 weeks after the injury. And then he was able to return about 4 or 5 days later and completed the season without any recurrence or pain. The second athlete had a very similar presentation, reported pain after making a cut, and afterward had pain afterwards, normal ambulation and pushing off of the toe of the hallux. This patient also received a similar cocktail with autologous conditioned plasma, Toradol, more soon after the injury, about 48 hours, and then returned to play within a full week. Didn't have any other issues. So while this was the only paper I found out there specifically mentioning biologics in turf toe, while preparing for this talk, I did speak to some of the sports medicine team physicians here at Rutgers, and for their practice, it's very similar. They do utilize these biologics more specifically for pain control and anti-inflammatory to get the patient into a rehab protocol sooner, as opposed to for true healing purposes. But this is something that is being done on a more wider scale. So now looking more at grade 3, and this is where grade 3 makes the conservative management become more of a discussion point. In many grade 3 injuries, there is a complete tear as well as there's an associated fracture or retraction of the sesamoids. But there are situations where there is a complete tear, but the general anatomy of the joint is maintained without a lot of retraction. So immobilization is a potential option. The treatment algorithm is very similar to grade 2. However, the immobilization period becomes significantly longer. So usually you're not going to allow these patients to weight bear at all, even in a cam boot. You're going to put them into a toe spica, and this immobilization can be up to 6 weeks. After that, you'll slowly begin the process, very similar to grade 2. You'll let them get back to a small residual gradual range of motion, progress to low impact walking, then to running, and then when they are finally able to run without discomfort, progress to more high impact activities. Of note that doing this route for grade 3, the recovery period may be 6 months or even more, so it is a significantly longer period of time. So looking a little bit more at kind of the literature surrounding non-operative management, really the big one comes from the more historical paper from 1986. This was one of the first big papers published about turf toe. So 1986 by Clanton, he had a case series of 56 injuries from 53 athletes, 51 of them football players, while he was at Rice University, and they all sustained their injuries while playing on an artificial turf surface. So the one strength of this was that all athletes that sustained this injury were functionally treated the same. They all went through a relatively standardized regimen of rice therapy. They rested, they iced, they elevated, and they were supportively cared with tape, orthotics, and a very gradual return to play. The time lost was a range from 0 to 46 days, and one of them needed to be operated on, which failed non-operative management. One of the biggest limitations looking at the study was that at this time, there was no formal grading or classification of the injury. So there was no delineation who had a low-grade injury, who had a high-grade injury. It is my best guess to extrapolate that the patient who had needed 40 some more days probably had a higher grade injury. Patient who did fail non-operative management maybe was a grade 3 or higher grade that needed to be surgically managed. But these are kind of more speculations as we don't know exactly what grade of injuries they had. But showing the outcomes from this paper that almost all of them, basically all of them went back to play, really formed the basis that non-operative management can be the key for all turf toe injuries. So now we'll move on to talking about operative management and start off with, we'll take kind of a top-down look view into literature as what is really the role of operative management. So in the literature, it's pretty unclear, especially when it comes to the evidence or higher level evidence studies, where the role of operative management comes in. A lot of the literature out there for operative management are case reports of operative management, which show, the outcomes are relatively good, but these are limited by, small sample size. And many of the older studies that are out there don't really indicate what grade of injuries the patient had. So there's not a whole lot of evidence to support really an evidence-based decision-making. But we do know that functionally, the vast majority of turf toe injuries can be managed non-operatively. So in this, so we saw this historically in the last paper as all of them were managed non-operatively, as well as a 2013 study where they found that the incidence of surgically treated turf toe injuries was found to be less than 2% that actually needed to have surgery. But those who had a sesamoid fracture did have a higher association of needing to be managed operatively. So going through the literature, this was a list of more of the, the comprehensive accepted indications for when you'd surgically manage a turf toe injury. So the big indications I found were vertical joint stability. So an unstable joint where your vertical Lockman test shows gross subluxation or even dislocatable joint, a large capsular avulsion with instability, significant retraction or proximal migration of the sesamoids, fracture or diastasis of a bipartite sesamoid, if there's evidence of loose bodies or osseous fragments in the first metatarsal joint. A chondral injury was reported in some incidences, and the big one that kind of was uniform was failure of conservative management. But how you define this is a little bit controversial. Some papers use a period of 6 weeks, some use 6 months, some use up to 3 months as what they determine as a cutoff for failing conservative management. The two that I've italicized here, which we'll talk, this one, traumatic hallux valgus, which we'll talk a little bit more about later, is one of the more accepted indications for performing operative management of turf toe, as well as chronic deformity, which we won't cover today. So for your operative treatment, your approach to injury, it can be approached from either the medial or the lateral side, depending on where the location of the injury is and what part of the plantar plate you need to access. You can use kind of a J-shaped incision that comes around the medial side, that comes around the lateral side of the joint or the medial side of the joint, depending on which side you need to access, or you can use a dual incision, which can be utilized in this middle image. In all approaches, the most important thing is you need to visualize the joint as well as to visualize and protect the digital sensory nerves of the hallux, which shown in this picture here from a paper. You kind of make sure that you can find and protect these nerves, or otherwise the patients are going to have sensory loss to the bottom and it will be problematic. So when it comes to actually repairing the capsular injury itself, a lot of these capsular injuries are distal it usually comes off of the proximal phalanx. It very rarely, if ever, comes off of the end of the metatarsal side for the plantar plate. If the capsular injury has been identified to be repairable, you can just use simple end-to-end repair with heavy non-absorbable sutures such as a fiber wire. If end-to-end repair is not possible, given the injury is very distal, the distal tissue is not amenable to repair, advancement of the plantar complex can be done to the proximal phalanx through either a bony bridge to be tied across or suture anchors into the proximal phalanx. And we'll show a little graphic later on in the next slide about how this is done. One consideration to be mindful of is how to address the sesamoids. So in high-grade injuries, the sesamoids are often involved whether through fracture or there may be a diastasis, which through bipartite sesamoids. And the overall size of the sesamoids makes it very hard to fix them. It's been reported in the literature that you could fix these with cannulated 1.5 millimeter screws, but in many of the reports, it's just functionally not very feasible given how small they are, how they may be comminuted, which then makes it functionally impossible to fix these. So as a result, many report excision of the distal pole of the sesamoid or even entire excision if necessary. So when this is done to fill that defect left behind by the sesamoids, you would do a tendon transfer of the abductor helicis to the medial aspect of the plantar plate, and that kind of fills in the hole and also used to augment your repair. So this is kind of a schematic showing one possible way the repair can be done. So as seen here, if, for example, this distal segment was, very stout and amenable, you could just do simple end-to-end repair, or if you needed to, tag sutures here and advance it onto the proximal phalanx, whether through bony bridges or suture anchors. So while coming across these treatment options, I noticed the sesamoids are often excised. So it led me to wonder how important are the sesamoids and what happens if you do excise them. So looking at that, there was a paired biomechanical study from 1994 and 1996 that really actually studied this, looked at what is the biomechanical effect if you do excise the sesamoids, and they used cadaveric studies for this. So in the 1994 study, they focused on the FHB, while the 1996 study focused on the FHL. In both studies, they used 12 specimens. They isolated the first metatarsal joint, and they tested different conditions with sesamoid excision. For the 94 study, you're looking at the FHB, they compared the native joint to a distal hemiresection of the medial sesamoid, a full medial excision, and if you excised both sesamoids. In the 96 study for the FHL, they did a similar comparison with intact, but they also looked at distal hemiresection of the lateral sesamoid as well as complete resection of just the lateral sesamoid and compared it to all. And then the test was they hooked it up to this apparatus with a clamp and a load cell, and they wanted to see how much force you needed to generate through the tendon to resist the flexion effect of the tendon. And they tested these at different degrees of dorsiflexion. So what they found at the end was that there was not a significant change in the force needed if you had a distal hemiresection of the medial or lateral sesamoid in either tendon. They didn't test the lateral sesamoid for the FHB, but they found that resecting the entire sesamoid had no real effect on the effective strength needed. It was a little bit different for the FHL, as once you took out an entire full sesamoid, the effective moment force that could be generated did decrease, but in most of our procedures, it's really the medial sesamoid that is being resected. So what this means clinically is that this could correlate to a potential loss of push-off strength or power that patients should be counseled on if a possible sesamoidectomy is necessary. But it's unclear in the literature whether or not this is actually borne out clinically with patients and results. So now that we've kind of gone through what operative treatment entails, kind of look at generally how do these patients do. So there's a few studies out there, mostly case series, but this was one from 2024 in the UK that identified a series of turf toe injuries. The exact number they identified was not listed, but in the end, they found a group of 20 patients who they had to have surgical treatment. In their study, they mentioned that of all the turf toe injuries they identified, those for grades 1 and 2 were treated non-operatively, and grade 3 injuries were given a trial of non-operative period up to 6 months, and then given the option of surgical management if they were not satisfied with their outcome. So in the end, the final 20 patients who they had that underwent surgery had a mean age of 32, almost 33 at time of surgery, and which I found this paper relatively useful, is that this was one of the only studies that was not specifically focused only on elite athletes. While they did report that 17 out of 20 patients self-defined as athletes, none of them were mentioned to be athletes or collegiate or any kind of higher level. So the surgery was performed by the same surgeon. They had the same post-op protocol, and they reported their outcome scores on the MOX FQ score. So the higher numbers on the score indicate more significant pain. So thus, the preoperative and postoperative difference of lower scores postoperatively indicates that the patient had significantly less pain, and as a result, they felt they had improved outcomes. So in this group of surgery treated patients, all of them, except for one, had sustained their injury from some form of sport, likely recreational, aside from the one patient who had a motorcycle accident. All of them returned to their prior level of activity level or participation in the level of sport that they played. So overall, this result showed that the results after surgery were relatively favorable. The one note I had on this paper was that they didn't delineate how many patients had grade 3 injuries that they were able to successfully treat non-operatively. So that would have been a good thing to find, as if they showed that a lot of them could have been treated non-operatively, it could swing that, grade 3 injuries, you could also initially manage most of them non-operatively. But it did have value in that this was one that was not specifically targeted on elite athletes. So in another case study, this one targeted specifically at elite athletes, was a study in 2018, came out of the University of Alabama and the American Sports Medicine Institute down there. So in this retrospective case series, they identified 15 patients who had surgical intervention for their turf toe. In order to be included in their case series, you had to have a grade 3 injury or grade 3 injury that was identified and had to have been playing football at least a high school varsity level or higher to be included in the study. So in the end, they had one patient who was denoted as a professional. It was unclear how professional this was, whether this was NFL or some variant of it. 9 D1 athletes, 2 of them were Division 3 and 3 high school athletes. Mean age of surgery at the time was about 19 years old. So 10 of these patients had surgery acutely or within 6 weeks of sustaining their injury, and the remaining 5 were reported to be a mix of those who either elected to wait, for example, wait for the season to be over to have their surgery, or had just had a misdiagnosed or missed injury that presented later. At their follow-up, they reported on the AOFAS HALEX score, and they found that their mean score was a 91.3 with a range of 92 to 100. In this kind of bucket of 90 to 100, usually denotes that the patients had an excellent outcome, very close to having a normal HALEX or a non-injured HALEX. So as a result, they had relatively good patient-reported outcomes. So one thing to note is that their study reported that although 11 out of 14 patients did return to competitive play of football, they did remove one patient who had a complication and did not complete the final follow-up survey, so he was excluded. 11 out of 14 did return to play competitive football, but they did make a return to note that of those 3 who did not return, they cited reasons unrelated to their injury. So it appeared that they did not have a reason that was injury related that they couldn't return. They cited more as did not want to play at the next level or, quote, weren't talented enough to go on to the next level. So overall, patients from this study appeared to also do relatively well and had a good return to play rates. So now we'll look a little bit more at the specific variant that draws a bit more attention towards operative repair, is the traumatic hallux valgus or the traumatic bunion variant. So as we kind of mentioned before, this injury is often seen more of a valgus-directed force and can often be seen when the player is making a cutting or a planting move on the field. So these are also graded on clinically graded on a severity scale and can represent an acute variant of turf toe that appears within weeks of injury or can develop as a more late chronic sequelae of a prior injury. So usually in these injuries, the entire medial and medial plantar complex apparatus is often disrupted, and this leads to an unopposed pull of the adductor hallucis, which begins to pull the phalanx into valgus on the first metatarsal. So when we think about treating these, the more specific consideration that we have to do with this is usually you have to take off that unopposed adductor pull, which is often used by an incision in the dorsal first web space to release that tendon, as well as you're often going to do the modified, the J incision along the medial side, as that's usually where the damage to these structures are. But this may also need to be combined with a lateral approach if there is evidence of damage to that side as well. During this surgery, you are also doing a modified McBride bunionectomy, which is resecting the eminence of the medial side of the metatarsal head to kind of help realign the alignment of the joint and take it out of valgus. So looking specifically at the outcomes of this did seem to indicate a more significant injury. So in the literature, there's a 2017 case series that specifically looked at the outcomes of traumatic bunions in athletes. and how does it represent in their outcomes. So in this case series, they identified 19 athletes, 12 of them being from the NFL, 6 were collegiate, and 1 who appeared from the description in the paper was a high school athlete who was recruited and had committed to be a Division I college athlete. The average age of the patients in this study were approximately 25 at the time. 8 of them needed a plantar plate repair in addition to their modified McBride bunionectomy for their traumatic hallux valgus. There was a much larger time range of surgery, but on average was performed approximately 4.5 months after surgery. So one of the big takeaways I found from this paper was that their outcomes were not quite the same as the prior studies. Their outcomes highlighted that this is a much more significant variant of turf toe. 1/4 of the group, so 5 out of the 19 did not return to play at all and did not return to play whatsoever. So of the group that did return, 4 out of 14 stopped playing within 5 years, and many of those did not return to their prior level of performance. It is unclear whether or not the group that retired very rapidly were the older players on the older end of the spectrum, as our range was 19 to 33, and they were the professional players who decided it was time to retire, or if they were just unable to play anymore. But it does show that this does represent a much more significant injury. So after looking at all about how these operative cases do and how all these patients did, we'll kind of back up a little bit and look at the big picture when it comes to returning to play. So when looking at overall return to play, all grades of turf toe have a pretty good return to play rate, regardless of their level of performance. So whether you're a local all-star who likes to play basketball at the East Brunswick Community Center at 9 o'clock on Thursday nights, plug out there for Jared, there is a game tonight at 9 p.m. Or if you're playing prime times on Sundays during the fall, overall patients relatively do well. So one recent example is Patrick Mahomes up here, who had a turf toe injury in 2020 and reported that he played through it and won a Super Bowl that year and then had off-season surgery. And since then, he's still been playing at a very high level. So it's fair to say that he had a very good return to play, but it's not really clear how severe or what grade he had for that injury. It was not reported. So while overall turf toe has a very good return to play, given that, high-grade injuries comprise a very small proportion of the injuries, the reports do show that if a high-grade injury is sustained, it has a much more significant effect to be potentially career-threatening. In the 2021 study by Chan, they found that the injuries that were graded as severe from this study of collegiate athletes, 36 of them ended their season and 16% of them did not return to playing after that. And many of them who did return to play did not return to their prior level of performance, which we'll see a little bit more in a paper later on. So looking into more of the larger reviews and analysis of regarding return to play, there was a 2019 large systematic review in the Journal of Sports Medicine by Bopat. And in this systematic review, they ended up with 112 patients, with approximately half being treated operatively and half being treated non-operatively. One of the major issues and one of the major limitations of their eventual analysis was that the majority of literature that was out there didn't provide a true classification of what grade the injury was to these patients, and it led their final return to play analysis being entirely skewed and functionally entirely based off of operative patients. So when they subdivided the 47 patients that they had grades on that were treated surgically, they resulted in 17 professional athletes, 24 collegiate, and 4 high school athletes. Among them, they found that the return to play was not really significant. The one outlier was this grade 1 injury, which we'll talk about later, actually was a professional athlete who elected to have that surgically managed. But overall, they found that the professionals did return to play sooner than collegiate or high school athletes, which may be as a result of the professionals have higher access to rehabilitation care, supportive care, and they have a more financial incentive to getting back sooner. So overall, they did find that the return to play and sport is tied to the severity of injury, as it took almost 16 and a half weeks, which equates to approximately 4 months for any grade 3 injury athlete to return. So it kind of gives us a guideline when we're treating patients with high grade injuries, how much time they can expect to miss. Finally, there was a 2020 study that looked specifically at NFL players, and they used publicly available NFL data to identify patients who had high-grade injuries in kind of a way that I'll touch on, and how much time they had to miss. They defined a high-grade injury in which a patient eventually had to either receive surgery for that injury or they missed 2 or more weeks of action. And they define return to play as returning for a single play, any play at all, in a preseason or regular season game. And they define return to prior performance as surpassing 80% of their pre-injury performance statistics. For the sake of the study, given that linemen don't truly have performance statistics, this was focused solely on the skill positions of quarterbacks, running backs, wide receivers. So identified 53 players, 28 of them were treated non-operatively and 25 were treated operatively. They found that the non-operative group had a 100% return to play, and 78% of them were able to return to their prior level of performance. The one big takeaway from this, which kind of highlighted also that higher grade injuries are more severe, is that of the operative group, 20% did not return to play at all. Only 80% returned to play, while the most significant value is that only 27% actually were able to return to their prior level of performance. So it really does highlight that if a high grade turf toe injury is sustained, this can be a relatively devastating injury for the elite athlete, or really any athlete, as their return to play may be severely limited. So as a final note, I kind of wanted to, give a little bit of kind of take a look at, given the name turf toe itself, and given that right now there's a lot of attention in the media about the quality of turf. And I know that with the US kind of in the talks for hosting the World Cup and their talk for converting all the fields to grass, I just wanted to see whether or not, turf really does have a big role in causing injuries. So in this graphic here, in this media, this injury is dear to my heart. It does show that, at least in this anecdotally, there are significant injuries that took place at MetLife Stadium on that turf. But the question is this just, anecdotal, or is there really data out there to support that there is more incidence of injuries when playing on turf? So the studies show that perhaps this may be true in the elite NFL athletes. In a 2019 study that compared injury rates of players in the NFL sustaining injuries on turf or natural grass, they did find that there was a 16% increase in injury rates while playing on turf. But in a 2022 more recent systematic study, this looked at studies looking at injuries on turf and grass for all levels of competition, whether you're a professional, high school, youth. They found that there was really no significant difference when you're looking at the new generation of turf. The older generations had a more significant leaning towards turf causing more injuries, but the more newer generation found that they were equal, and turf doesn't really seem to make a difference. So in the end, it might make a difference for the elite athletes as they're, bigger, stronger. They can generate much more forces onto the field and need, maybe that does play a difference. For the local high school athletes, it doesn't seem that turf is really causing a big role in increasing any injury rates. And as a last thing, kind of we touched about, there's a lot of attention being played to kind of helping prevent this injury. Dr. Schaefer kind of put me onto this. There's a lab out there in UVA by Richard Kent, and there's an entire lab dedicated to studying the effect of shoe wear and turf, on the forces being generated. They named this machine the Beast, which is the BioCore Elite Athlete Shoe Turf Tester, and they basically check to see what are what kind of strength, what kind of loads you need to generate to cause certain cleats or shoes to flex, and how stiff are the soles. And they also see how much traction effect is on the turf, see how much the turf has a lock onto the shoe, which can play a role. Is if the toes kind of lock into the turf, you have a much higher likelihood of having this injury as it becomes planted in there. So definitely a lot of attention being given to prevention, as they say, an ounce of prevention is worth a pound of the cure. So now we kind of
real
talk.
quick, just to comment on the Beast as well. I think they intermittently will use that to test the playing surfaces, because they can alter the properties of the fields. They can adjust the fill rate. They can do a number of different things to make sure that playing surface has enough give. So it's not just for shoes. They're also using it to monitor the variables for the playing surfaces themselves at these stadiums.
Cool, thank you. All right, so I know we've talked a lot about the literature and everything about turf toe. Let's go into a few of our cases and kind of see how things play out. So our first case is patient HH. This is a 19-year-old male. He was a collegiate Division I football player. He reports that initially during practice, he was running a route while making a cut, he felt a pop in his left hallux. He reports that a similar injury happened while the patient was in high school, but at that time it was self-limited, didn't really seek formal care, and it resolved without formal treatment. No significant medical history. On the exam, he was able to ambulate with some pain, had some medial joint line tenderness, but overall no gross clinical instability. At this time, this was treated more clinically. There was no imaging obtained, and the patient was treated more with orthotic in the cleat, given a steel plate, and were allowed to return as tolerated. So the case does continue, and now about 4 months later, this is the off season. He presents again with continued pain. He reports that he did complete the season with the plate in his cleat. He did the treatments, did the rehab. Reports that overall he is feeling better, but still having a lot of pain with walking, running, and unable to do a lot of the activities that need significant push off from the forefoot, such as doing lunges or really doing deep drives when sprinting. His exam was grossly similar, still tenderness along the medial joint aspect, but no real gross instability. So at this point, an MRI was obtained. Really from this MRI, we do see that there is some edema in the tibial sesamoid, but there's some evidence for a probable non-displaced fracture of the sesamoid. But overall, there's no gross tearing that we can see. There's not a whole lot of edema, but there may be evidence of a small strain. So I guess at this time, I'll kind of poll the audience. Is there anyone who would try to go more aggressively with this patient given his activity level, or just kind of stay the course, conservative management? So he played the rest of the season, but off season still having pain, difficulty sprinting with push off motions. Yeah. So Joe Martin in the audience saying that he probably stay the course, but maybe at this point, maybe try something a little bit more in depth, maybe some biologics, which is basically what happened. So kind of the recap there. So after the MRI was kind of evaluated, the patient underwent continued conservative management, did have a trial of injection therapy. Was not clear what specifically was injected. Might have been PRP, but was not specified in the charts. But this really didn't provide a whole lot of significant relief. Patient still had a lot of pain. And about a month or two later, patient had another repeat MRI just to assess kind of what's going on now. No, he did not feel a pop. He had been continuing to working with rehab, didn't feel it was getting any better. There was no T2 signal. So on this repeat MRI obtained a few months later, they showed a grossly kind of unchanged appearance there. But the big important thing to note is there was still some continued edema on the sesamoids, and still a given appearance of a fracture line, which at that point was read for concern that there may be development of some sclerosis at the time. So kind of discussing with the patient at that point, kind of sought another opinion. Given the patient wanted to continue his collegiate football career, he did elect to have this operatively managed. So the indication was more for failure of conservative management. The patient did elect for surgery. So from the operative note, an exam anesthesia was performed and did reveal that there was a positive Lockman at the time. And this intraoperative video kind of shows that there was a continued fracture through the sesamoid, which didn't heal. And every time the patient kind of flexed, there would be flexion through that fracture line. So in the end, the medial sesamoid excision was performed. The plantar plate was examined, and it didn't show a whole lot of gross tearing, but there was evidence of some fraying and prior injury. As a result of the excision, the abductor was released and transferred to fill that defect, and then suture anchors were used to tack any kind of remaining, not great tissue to the medial proximal phalanx. Patient had a relatively uneventful post-op recovery, and he did go on to participate in D1 football for about 2 more seasons until he graduated. Next case was a 27-year-old male, also presented with right hallux pain. This patient was more recreational player. He reported 2 incidences in the preceding weeks where he was playing recreational basketball, and he felt some sharp pain in 2 instances where he was pushing off and jumping and landing on his right hallux. Overall, he walked into the office, had some diffuse mild swelling and tenderness, but more at the lateral base of the first metatarsal, and didn't really have any gross clinical instability. Radiographs were obtained at that time, which did show that there may have been evidence of a prior injury. There was some kind of small density there, maybe some small prior avulsion from that lateral first metatarsal, but overall, nothing very remarkable here. There's no real evidence of sesamoid retraction or anything like that. So the patient was managed conservatively and had some activity modification given his activity level. So again, this case continued. So the patient was doing well, but then it presented about 5 months later saying that he had continued pain. And there was an exacerbation event about a month prior to presentation when he was walking on the beach and was walking in the sand. So on his exam this time, the exam was grossly unchanged, but there was no significant swelling, but he continued to have tenderness and pain at the first metatarsal joint. There was no instability, but any time with plantar or dorsiflexion, there was a lot of pain exhibited by the patient. Radiographs were repeated at the time. So poll now is anyone who would also elect to do anything more substantial for this patient, or also kind of continue the course, activity modification, and kind of see how he does. Yeah. So initial management of this patient was kind of the continue activity modification, but the patient kind of did seek out an MRI just to kind of see why he's having continued pain. So an MRI was obtained. which did show that there was a more significant injury than the radiographs were able to show us. So the MRI did show that there was some partial tearing of the plantar plate medially and laterally. So this
Just something
patient,
to put on your differential every once in a while when someone has this sort of injury with continued pain at the joint. You got to think about an osteochondral lesion. Sometimes you can't see it on the X-ray, but sometimes the MRI can be helpful in showing those as well.
yeah. So this patient also kind of had a discussion, the failure of conservative management, which was also his main indication. He also proceeded to have operative intervention. He was still having pain and elected for repair and wasn't able to participate in the daily activities he wanted to, basketball, etc. So in this case, actually, because of kind of what was shown on the MRI, a nanoscope arthroscopy was done in that first metatarsal joint, which did show sort of these chondral fraying lesions, which were debrided. And then finally, using this distraction, a dorsal incision was used to help repair the plantar plate. Looking kind of through the dorsal incision, it was shown that there was some chronic damage and disruption to that plantar plate found really at the distal insertion to the proximal phalanx. So the remainder of the plate was released, and then the plate was advanced onto the proximal phalanx and tied over using drill holes and tied over with anchor screws. So post-operatively, the patient also did very well, advanced, and has been back to all of his recreational activities that he enjoyed doing. So this is our third and final case. This is case JL. This is a 23-year-old male, also Division I collegiate athlete, presented with left hallux plane immediately during a game when he felt his hallux become dorsiflexed when he planted on the turf. He had immediate pain, came to the sideline, and was initially temporized treatment with tape and had an injection and did complete the rest of the game. He had no real past medical history. For this patient, the exam showed diffuse edema and ecchymosis along the first metatarsal joint, with edema extending diffusely kind of across his distal midfoot. He was very tender to palpation, a lot of pain with a manipulation and motion of the joint. So with this patient, X-rays were ordered. So one of the big findings here is that there's significant space and diastasis between the sesamoids. So in this patient, actually, this patient was known to have bipartite sesamoids because he was being treated for an unrelated ankle injury earlier in the season, which there were foot X-rays obtained, which actually gave us a decent comparison as to how much diastasis now retraction there was. An MRI was also obtained immediately, which did show significant edema and diastasis through sesamoids. So I guess in this patient's case, obviously, exhibits a much more higher grade injury. In a sense, is there anything, I guess, in terms of this for this collegiate athlete, is there any special considerations anyone would consider? Would you recommend they get shut down for the rest of the season? Would you allow them to continue if they wanted to, or just kind of pull people's thoughts on that? Yeah. Would you shut them down right away? Yeah. So
sometimes there's more pressures and play and shut that out with this season. Time of this injury, but not everybody wants to go through it. They want to be a player. But if I really shut them down, then it's like that. It's tolerate it. There's one.
yeah, so definitely drummer saying definitely operative indication at this point for this patient. And the discussion was had with the patient whether or not to shut them down for the season. It was already discussed with the patient this is going to be an operative injury, but the patient really wanted to continue the rest of the season. So he was treated with injections, taping. He was able to play 2 more games on this injury, but during that second game after the initial injury, he seen an ankle injury, which he felt another pop at that hallux, He did get taped again and was able to complete the game, but an immediate MRI was done after that to kind of assess, what had happened, which at this time, I guess the more relevant imaging is this bottom left, which shows the prior MRI on the left and the new one on the right, which does show that there was a, further damage, and now there's a complete rupture with further retraction of this sesamoids. It's definitely a tough case to discuss with the patient. Probably should, he definitely could have been shut down, but, wanted to continue playing, kind of accepted, what the case would be, given that it was really operative. He had this kind of decision to keep playing. So after this injury, patient underwent a further evaluation at an outside facility. It was noted from the documentation that at that time, he was already beginning to develop a clinically apparent hallux valgus, as well as somewhat of a cock-up deformity. And surgery was prepared at that outside facility, which is where they did a tibial sesamoidectomy, an abductor helicis transfer to fill the void left by the sesamoidectomy. And there was also an adductor tendon release. It's noted that this was kind of part of the usual triad this outside treating surgeon does for these injuries. So post-operatively now, it's been about 5 or 6 months. Patient's been progressing well. It has been clear to return to football activities at this point.
And I think the challenging part of that case, or the discussion was whether to let him play again. He showed an MRI that showed some worsening of the symptoms, but worsening of his injury, but he was going to get surgery anyway. I think shutting him down, I don't think where he was prior to the last few games playing was going to change what was going to happen in the long run. And that was the discussion, that, he had, right. I mean, you don't think that was going to resolve with conservative treatment prior to the 2 games
right
that he played, right?
Right. Yeah. So it really not much. Wouldn't really change. It was more of a do the treatment earlier, or do you play through it and do it a little bit after?
Yeah. I don't think a whole lot of people would try to play through that. It's probably a relatively tough individual to make it through that injury and still play.
Right. And even after the second re-injury, continue the game, definitely quite painful. So kind of to wrap up, mild and low-grade turf toe injuries are often a clinical diagnosis, and the mainstay treatment is conservative, and the vast majority will get better with supportive care of the symptoms, and they generally return to play. The higher grade injuries do have significant impacts for the elite athletes and athletes in general. The diagnosis is usually confirmed on the MRI if radiographs are not really apparent, and the hallux valgus variant does pose a higher risk for being unable to return to prior activity. From the literature, it shows that surgical treatment does show to have good results for athletes trained to play or higher activity patients who are unable to perform their activities due to continued pain from their injury. So kind of wrap up, kind of try to make a little bit of a flow sheet of, how, in my head to kind of manage these injuries. So for your low grades, grades 1 and 2, generally go straight to conservative management. Usually most of them will get better. If there is treatment failure, you kind of have a joint discussion with them based on what they want out of their, life, their activities, and whether or not they're an athlete. And from there, you can kind of make that decision whether or not to continue the activity modification, continue treatment, or go more towards the operative repair. When it comes to grade 3s, I think that if there is significant evidence of sesamoid fractures, diastasis, proximal migration, I think that should be kind of an indication that goes lean more straight towards an operative repair, as these are often not going to get better. You're going to have significant altering of the biomechanics of the joint, and these should be managed more operatively. Whereas if the normal anatomy is still maintained, if it's a lower demand patient, not really an athlete, you could consider trial of non-operative management and see how things go. Whereas if they're like that last case, a very high demand athlete, it's kind of a joint decision how quickly they want to go straight to an operative repair. So it's kind of how I kind of structured it in my head. And with that, that wraps it up. I want to thank you for all the faculty who helped with this talk, Dr. Schaefer, Dr. Fleming, and sports faculty, Dr. Gadden, Dr. Kristofiak. Those are my references, and I'll take any questions.
Then I'm going to ask this question probably more pointed to the radiology and Dr. Schaefer, if he's still on. Differentiating between like a sesamoid stress fracture, which can also be a cause of plantar plate pain, and a bipartite sesamoid fracture and an acute fracture of the sesamoid. I feel like I struggle, making that diagnosis, and it kind of clouds for me. It's a challenge in terms of how to manage these, because I don't feel like I'm making the diagnosis accurately, as to which of those 3 entities it might be. I don't know if you read anything about that in terms of the occurrence of a like the incidence of bipartites that occur with turf toes versus non-bipartites, things like that.
I think from what I saw out there is they mentioned that there's 25% of people that you could see a bipartite sesamoid, but I didn't really come across anything that specifically delineated on that specific part.
The other
I mean,
challenge
imaging
too is
wise,
that, go ahead.
no, I was gonna say, imaging wise, it is very difficult. I would say, in terms of differentiating sesamoiditis from stress fracture, I would never call a stress fracture unless I can actually see a low signal line in the sesamoid. If all I see is marrow edema, then you're never going to be able to tell whether that's an early stage stress injury or whether it's sesamoiditis from, for example, arthritis or something like that. But I think it's going to be more the clinical picture and the patient demographics that will help you make that distinction. In terms of fracture versus injury to congenital bipartite, that can also be tricky. But one of the things you can look for, similar to the case that was just shown, that the athlete that was just shown, you can sort of see that the apposing bone margins were a little bit more irregular and sort of concave, whereas with the congenital bipartite, they'll tend to be smoother, it'll be more well defined. Sometimes the X-rays correlation can help with that as well. But it can be hard. I don't know what the data are in terms of incidence of turf toe injuries in congenital bipartite sesamoids versus turf toe injuries in non-bipartite sesamoids. So that I'm not sure about. But in terms of how you would distinguish that, those are sorts of the things you can look for. But yeah, it can be difficult, as Charlie said.
I think it was a great presentation, Ben, on a topic, like I think people would say, oh, turf toe. We probably deal with a significant turf toe injury that has impact on players, play time, as well as, their future ability to play, like a significant one almost every season, if not every season, every other season. They are really tough, to deal with. And I think, everyone's concerned that, that I think you give a nice presentation on the positive outcomes of surgery performed well, but kind of the general consensus is that if you have surgery on your plantar plate, the chances of having problems afterwards are pretty high. I thought your presentation of the data was really very good.
Thank you. Yeah, definitely the data is promising, but I guess as a big picture, it can be a quite devastating injury.
Yes, for sure.
And you did a great job. One comment on a couple of things you said, in terms of the role of the sesamoids and removing them. I think there's a level 5 paper from Anderson saying, especially for high level athletes, if you need to remove one sesamoid, they can usually return to play at a pretty high rate, but 2, it becomes problematic despite the fancy biomechanic tests. So just from level 5, from someone who deals with the highest level athletes, that's usually problematic for returning someone to explosive play. And then with the bipartites you've showed, just keep in mind, not all of them look this clean where it's more at the waist of the sesamoid. Sometimes people will have a very small distal pole or vice versa. And in those cases, it can be more difficult. But the treatment can also change because if you do have a very large piece next to a very small piece, you can excise the very small piece and save what's left of the very big piece. You don't always have to remove the entire piece. And you can put a little bone tunnel through that. But there's something else to consider.
Got it. Thank you, Dr. Schaefer.
Just anecdotally, the importance of the doing from all over the Army regulations. When the students examined as far as combat readiness, if they had an injury or some severe problem with the first infantry joint, they were not combat qualified. And one point, if I'm active duty, in a conflict and to avoid service, generally these soldiers are given leave for a couple weeks before they were shipped out. Somehow there's an amazing number of hunting accidents involving the toe for opposite the hands. We had a plethora of that data. These are not all published, but the NP joint is important, not just the athletes.
Thanks, Dr. Malberg. All right. Thank you, everyone.
Hey, Ben, I have a comment. Swan here. Two
Mhm.
comments. First, an anecdote on a patient of mine. The trainer thought this football player had a turf toe, and they did. They might have had a mild turf toe. The mechanism was described, the typical mechanism. But it turns out they actually had a Liz Frank injury as well, a ligamentous Liz Frank that the trainer was. They were just trying to let this kid play, and he really couldn't. So just to remember, it's the same mechanism often, and so make sure you're examining the whole foot.
Yeah.
Yeah, and then number two, another anecdote. Personally, maybe 10 years ago, I suffered a pretty significant turf toe in one of our Thanksgiving football games. And number one, it popped and it hurt and limped around for a while, and it is pretty debilitating. The boot helped for, eventually I was booted for a long time. And then just wanted to mention the Morton's extension is like a godsend. That thing really works and it can
Wow.
get a player back on the field and back to running.
Well, I guess I was calling one thing out. Yeah, go ahead.
I was just going to say for athletes too, I saw a few of these for University of Maryland linemen. There's this putty you can form to the space of their first web space because a lot of these patients are at risk of getting a traumatic bunion. So in addition to a turf toe plate, you can put a toe spacer in there that will help prevent that valgus drive as they continue to play in addition to the turf toe plate.
Well, one thing I was kind of seeing out there between like some of the charts notes is there's I guess a carbon fiber and a steel plate. Is a steel plate still in use? I imagine that's probably much heavier. Is that kind of being phased out for the carbon fiber?
Are you talking about a spring steel?
Not maybe
when
not
you-
sure. How. Mm-hmm.
The steel plate pin isn't like a solid, heavy piece of steel. It's just as before they had carbon fiber.
Oh, gotcha.
They put like a rigid first ray into the shoe to try to prevent the bending, but it's not like a big hunk of steel. It's just pretty light and relatively flexible, but it's
Got it.
carbon fiber is stronger and lighter. That's why it's gone to that.
Gotcha. Makes sense.
Yeah, the spring steel is pretty flexible. I use them for athletes in Liz Frank injuries as they get back to play because it kind of limits how much they can load the midfoot. But it's shaped to the whole foot. The Morton's extension really just goes under the first ray.
Yeah. I'll show you a picture, Joe Moore. Right there. Yeah. What? I guess from this picture, this looks more like a post-op cast, but I'm sure you could probably put it on in the ER if you really needed to.